So starting back up with slide 7, which is the alpha-2 agonist. The drug that is considered the prototype drug for the textbook is clonidine or catapress. It's a selective alpha-2 receptor agonist, which inhibits the release of norepinephrine, and by doing so inhibits sympathetic outflow, which will decrease blood pressure. However, if you've ever given this drug IV, you know that if you give it IV, it can cause a rebound hypertension. This is also true with any time that you withdraw the medication too quickly. So if you're giving it even via oral use in an outpatient type setting, you want to taper this drug over at least 4 days. Also, you wouldn't want to hold this medication during a perioperative period because you would see your patient have increased hypertension. So clonidine can lower blood pressure and heart rate. It's used for the treatment of certain withdrawal symptoms. And then we see these drugs like Intuniz, which is an alpha-2 agonist, being used for ADHD. The classic adverse drug reactions, or ADRs, are bradycardia, AV block, palpitations, tachycardia, sleep disturbances, dry mouth, orthostatic hypotension, constipation, nausea. We can see leg cramps and urinary retention. In addition to the indications that I mentioned above, other clinical uses, which aren't as mainstream, would be for hot flashes, restless leg syndrome, substance abuse, sedation, and again, that would be more broadly the alpha-2 agonists. You really don't want to use a drug like clonidine, or for that matter, an alpha-2 agonist in general in a patient with a fresh MI, severe CAD or renal insufficiency. And generally speaking, you would want to check liver function and renal function before using this class of drugs. For the beta-2 agonists, they're used primarily in asthma and COPD treatment. These are the drugs such as albuterol or Ventolin, Proventil, Alupent, Maxair, Xopenex. They have an effect on smooth muscle, and they cause dilation of bronchial passages. They also vasodilate the muscles in the liver and uterine muscles. The ADRs here are generally things such as anxiety, tremor, palpitations, and you would always want to check a patient's potassium level before starting the drug as well as throughout the use of the drug, as it can cause hypokalemia. That would be the beta-2 agonist. Adrenergic antagonists, these are your blockers, you would see either alpha blockers or beta blockers. And basically the adrenergic antagonists block adrenergic receptors directly and indirectly by decreasing norepinephrine release within the sympathetic nervous system. They either block alpha-1 receptors in the blood vessels, beta-1 receptors in the heart, alpha-1 receptors in the bladder, neck, and prostate gland. And things to consider would be that within the alpha-1 agonists, we have selective and non-selective alpha antagonists. Our non-selective alpha antagonists include drugs like phentolamine and phenoxybenzamine. We only see these drugs really being utilized in treating pheochromocytomas. We don't see this type of tumor very often. This is classically the worst headache of my life. That's when you look for pheochromocytoma. Why do we use these drugs? They prophylax against the release of norepinephrine from the tumor, which causes the hypertensive crisis that we see in pheochromocytoma. And for the acute care NP students in the class, we will certainly go over that in more detail throughout the clinical courses. So again, just going through the slides, alpha blockers, again, they block the alpha receptors leading to vasodilatation. They're used to treat hypertension, BPH, Raynaud's disease, and migraine headaches. Beta blockers antagonize or block the effect of catecholamines. These are drugs that can be selective to beta-1 receptors or non-selective, again, to beta-2 receptors. That should say, I'm sorry, drugs can be selective to beta 1 receptors or non-selective to beta 1 receptors. My apologies. And these are drugs mainly used for hypertension and post-MI. So we'll go over those in more detail coming up. So what are your classic alpha blockers? Your classic alpha blockers or selective alpha antagonists are more widely used for decreasing blood pressure. They do this by causing vasoconstriction, and they are also for BPH because they help to relieve outflow obstruction. That's your classic Flomax. You have to be cautious with the selective alpha antagonists because they cause postural or hypotension and can lead to falls. Think about it. Classically, the alpha blockers are used for elderly men with BPH that also have hypertension. So you have to be cautious. I would say you want to start the dose low and you want to gradually increase the dose because otherwise you will have a patient potentially who is falling. You also have to check creatinine clearance. It should be greater than 30. And remember that the liver metabolizes most of these drugs in the alpha blocker classification. So you want to be cautious in hepatic impairment. Again, orthostatic hypotension and syncope are the biggest ADRs along with fluid retention. Beta blockers, which you're probably fairly familiar with, but let's go through them. These are the beta adrenergic antagonists, also known as blockers. They act by occupying the beta receptor sites, and they prevent, as mentioned previously, they prevent catecholamines as well as other beta agonists from occupying these receptors. The majority of the beta 1 receptors are in the heart and influence heart rate as well as myocardial contraction. You'll also see in the renal system some beta receptors, which helps to decrease blood pressure as well. And they help to decrease intraocular pressure in the eye. There's also beta receptors there. You want to dose reduce beta blockers in patients with renal disease, patients who have diabetes. You do not want to give beta blockers in patients who have AV block. We do see beta blockers as the drug of choice in hypertension, especially hypertension in children. We utilize beta blockers for angina as well as post-MI. Treatment with beta blockers post-MI can decrease mortality by 30 to 40%. So for the acute care students, you'll certainly be getting more dialogue on the beta blocker uses for some of these patient populations. We also use the drug for migraine prophylaxis in addition to the classic cardiac uses that are listed here. Propranolol is the beta blocker of choice for migraine therapy. That would be 20 milligrams to 80 milligrams, TID to QID for migraines. You have to be cautious in using beta blockers. You never want to just abruptly stop them. You want to taper off the dose. You have to look out for bradycardia, congestive heart failure symptoms, pulmonary edema, hypotension, of course. Fatigue, weakness, and dizziness can also be a real issue with this particular classification of drugs. Cholinergic agents, which are also known as all of the titles above, have either a direct acting effect or an indirect acting effect. So we're going to talk about the drugs that have a direct acting effect and an indirect acting effect. So I'm really going to sort of skip this slide and just say that really these are agents that mimic the action of acetylcholine, okay? And we'll go into more detail in the next slides. So the main uses of the cholinergic drugs would be the following: to decrease intraocular pressure in glaucoma, to treat atony or to increase the tone, rather, of the gastrointestinal tract as well as the urinary bladder, more so really for use in the urinary bladder, and to diagnose and treat myasthenia gravis. Physostigmine is used to actually treat anticholinergic toxicity, and that's a medication that for the acute care NP students we'll talk about in your pharm-specific courses. I'm not sure if the other groups will need to know how to treat anticholinergic toxicity as much as the acute care NPs. So again, skipping that, but not to be forgotten in terms of importance. When we talk about drugs for glaucoma, I will just mention, again, this will be in a separate chapter that we may not get to in this course. The FNP students will see this down the road, but just remembering the drugs such as pilocarpine and carbachol are the medications to treat glaucoma. The muscarinic receptors, just to keep this in mind, are located in the eye, the heart, the blood vessels, lung, GI, urinary bladder, sweat glands. So when we use these cholinergic drugs, we're going to have quite a wide range of effects depending on what we're trying to go after here in terms of treatment. Bethanacol is a medication that increases the tone of the detrusor muscle and causes bladder contractions, and that's what we really see it used for. We do not see this drug to increase gastric tone, although that is an indication for it. It is really used by urologists. If you give this drug subcutaneously, you'll see effects 5 to 15 minutes after dosing it, about 30 to 90 minutes after giving it PO. It's contraindicated in patients with peptic ulcer disease, any types of bowel obstruction patients, anybody who has hyperthyroidism or urinary tract infection. And again, it's to try to help increase bladder tone and contraction. Anticholinergic drugs are listed here. Belladonna tincture is an old medication that was used a long time ago in irritable bowel syndrome. I haven't used it in over a decade, to be honest with you. You will see drugs like hycosine or scopolamine being utilized for motion sickness. We used to use it as well in some of our lung cancer patients that had very wet lungs to sort of dry them out. Cogentin, the medication you'll see for Parkinson's disease and trying to combat those tremors. So let's talk about a few of them in more detail with these upcoming last few slides. So the anticholinergic drugs, they block the vagal impulses to the heart. They can suppress or decrease respiratory secretions, as I mentioned, or help decrease bladder spasms. They will relax the sphincter muscle of the eye or the iris. They can treat those rigidity, tremors of Parkinson's disease, and they help to treat the side effects of the psychotropic medications, the extrapyramidal or EPS symptoms that we see. Let's just go through them momentarily here. So atropine is our sort of prototype cholinergic blocker drug. Cholinergic blockers completely block the action of acetylcholine at the muscarinic receptor. So what these drugs do is they dry out the patient, okay? They cause dry mouth, dry lungs, they decrease the transit time in the gut, so it slows, or they increase transit time in the gut, so it slows the gut down. They cause decreased ability to see up close. If you ever get like a scopolamine drop in your eye, it causes mydriasis, so you can't see up close. I've actually had it happen to me, embarrassingly. It takes hours to go away. As a side effect, also, these drugs can cause excitation, agitation, hallucination, delirium. So, not the easiest drugs for patients to handle. Um, you also have to watch out for things like tachycardia, the lack of sweating that can occur, CNS changes, GI and bowel type changes like obstruction, constipation issues. And again, we can see these drugs being used, for motion sickness, overactive bladder, um, akinesia from antipsychotic drugs, used to treat tremors and Parkinson's disease. So a lot of sort of interesting uses depending on the drug that we're talking about, as mentioned here. And lastly, the cholinesterase inhibitors. These are the drugs that are fairly specifically used for either myasthenia gravis or Alzheimer's disease. And let's just talk about why they would be used for these two disease states. Keep in mind that myasthenia gravis is an autoimmune disorder where the immune system actually produces antibodies against the nicotinic receptors on skeletal muscle, which causes muscle weakness. I mean, that's really what's going on here. So, and then with Alzheimer's disease, this is a decrease in brain level, the brain levels of choline, as well as acetyltransferase. Now, going back to pathophysiology, those are both chemicals that are needed to synthesize acetylcholine. So these cholinesterase inhibitors, they increase the activity of acetylcholine at the cholinergic receptors. So basically, they can intensify acetylcholine activity at all the cholinergic junctions, like muscarinic, nicotinic, and ganglionic junctions. So they have a wide response, but we're seeing them as both a treatment for myasthenia gravis with neostigmine and pyridostigmine, as well as for Alzheimer's disease, with the classic drugs such as Aricept. You have to know that some of these medications, like tacrine, which isn't listed here, is known to cause elevated LFTs. So you have to check LFTs, including total bili. You have to be cautious for the inpatient group of NPs. You need to be cautious giving a drug like neostigmine along with succinylcholine or neostigmine with aminoglycoside antibiotics, because you can increase the risk of neuromuscular blockade. That's a real threat. Other sort of classic ADRs with the cholinesterase inhibitors are muscle weakness, fasciculations of the legs like twitching, cramps, spasms, headache, nausea, diarrhea, insomnia, and we do see a real increased risk of peptic ulcer disease. So a lot of Alzheimer's and myasthenia gravis patients will see increased gastric acid and peptic ulcer disease because of these drugs. Many of these drugs are available in oral disintegrating tablets, transdermal options, as well as liquid options, because so many of these patients who take them have muscle issues in terms of swallowing. So again, there are some options in terms of formulation. Okay, thank you.